Good morning, Maddy. Welcome to Intensive Care Primary Podcast. Today we are going to discuss about cardiovascular pharmacology. Are you ready?
Yes.
Good. So one of the common scenarios in ICU is a patient admitted with shock who have already had adequate fluid resuscitation. In this case, we often commence inotropes. Would you able to classify inotropic agents and list their mechanism of action for us, please?
Inotropes are substances which alter the force of cardiac muscle contraction. While inotropes can be both positive, which increase contractility, or negative, which decrease contractility, in common clinical usage, day-to-day, inotropes generally refer to drugs which increase myocardial contractility, thereby causing increased cardiac output. Excitation-contraction coupling in cardiac myocytes is dependent on an increase in intracellular calcium. This is caused by an increase in cyclic AMP, which activates L-type calcium channels via the activation of protein kinase A. This causes both increased calcium influx via the channels and enhances the release of calcium by the sarcoplasmic reticulum within the heart. Therefore, the common final cellular mechanism of all inotropes involves the increased availability of intracellular calcium in myocytes. Inotropes can be classified as those that are cyclic AMP dependent, which include the majority of inotropes, and those that are cyclic AMP independent. Cyclic AMP dependent inotropes can be further subdivided into adrenergic agonists, phosphodiesterase inhibitors, and glucagon. So first I'll talk a bit about adrenergic agonists. Their mechanisms of positive inotropy is via agonism at beta-1 receptors, which act via G protein-coupled receptors to activate adenyl cyclase. This enzyme dephosphorylates ATP to form cyclic AMP. As I outlined earlier, the increased cyclic AMP causes increased intracellular calcium in myocytes, thus resulting in inotropic action. Adrenergic agonists can be subclassified into natural ones. These include adrenaline, noradrenaline, and dopamine, and those that are synthetic, which include dobutamine, isoprenaline, and ephedrine. Another type of cyclic AMP-dependent inotrope are phosphodiesterase inhibitors. These inhibit phosphodiesterase, which is the enzyme responsible for the breakdown of cyclic AMP. Examples include Milrinone and aminophylline. The final cyclic AMP-dependent inotrope is glucagon, which is an agonist at G protein-coupled receptors, which causes increased adenyl cyclase, thereby increasing cyclic AMP. Cyclic AMP-independent inotropes include calcium itself, calcium sensitizers, sodium-potassium ATPase inhibitors, and triiodothyronine. So calcium sensitizers include levosimendan. This causes sensitization of cardiac myofilaments to calcium and stabilizes troponin C in a conformation that maintains cardiac contraction without increasing consumption of ATP. It does not increase intracellular concentrations of calcium. Sodium-potassium ATPase inhibitors, such as digoxin, increase intracellular sodium, which results in the disruption of the sodium gradient needed for the sodium-calcium exchange, thus resulting in increased intracellular calcium and increased inotropy. The final one is triiodothyronine, which is required for normal synthesis of cardiac contractile proteins, calcium channels, and the sarcoplasmic reticulum, which causes increased calcium.
Thanks, Maddy. That was a very comprehensive answer to that question. Now, we're moving into the second question. Can you please list the properties of an ideal inotrope? How does adrenaline compare with these ideal properties?
So the properties of an ideal inotrope can be divided into pharmaceutical, pharmacokinetic, and pharmacodynamic characteristics. If we first concentrate on the pharmaceutical characteristics of an ideal inotrope, these would include chemicals that are stable in solution, have a long shelf life, are cheap, can be delivered peripherally, and are compatible with other drugs. Focusing on adrenaline, this is a naturally occurring catecholamine that is produced in the adrenal medulla and has both alpha and beta adrenergic receptor agonisms. It meets most of these ideal pharmaceutical properties as it is stable in solution, has a shelf life of approximately 2 years, and is cost effective. It can be delivered peripherally, but the site should be observed frequently for signs of extravasation, which can cause tissue necrosis. As a result, we usually give adrenaline centrally. Adrenaline is incompatible with multiple drugs, so should be infused via dedicated line or lumen. Thus, it doesn't meet all the characteristics of an ideal inotrope. The pharmacokinetic characteristics of an ideal inotrope include rapid onset, being easily titratable, rapid clearance and metabolism, metabolized independent of renal and hepatic function, having no active metabolites, doesn't require concentration monitoring, and doesn't develop tolerance. Adrenaline also meets most of these criteria, as it has a rapid onset of less than 1 minute when given IV and is easily titratable via infusions. It has a half-life of 1 to 2 minutes due to rapid metabolism via monoamine oxidase and catechol-O-methyltransferase, which produces inactive metabolites and is excreted by the urine. Its metabolism is not dependent on renal or hepatic function, and it does not require monitoring of levels, making it useful for the ICU patient. The pharmacodynamic properties of an ideal inotrope include increasing cardiac output without increasing myocardial oxygen consumption, a high therapeutic index, minimal histamine release or hypersensitivity reactions, minimal adverse effects, non-arrhythmogenic, and suitable in pregnancy and pediatric populations. Adrenaline does increase cardiac output via beta-1 agonism and has other potential beneficial effects such as bronchodilation via beta-2 agonism, mast cell stabilization, making it suitable in things like anaphylaxis, vasodilation at lower doses via beta-2 agonism, and vasoconstriction at higher doses via alpha-1 agonism. It is a life-saving treatment for anaphylaxis and as such causes minimal hypersensitivity reactions. It is suitable for use in pregnancy and children. Given all of these advantages, it is on the WHO list of essential medicines. But unfortunately, adrenaline does have its disadvantages, including a narrow therapeutic index, multiple adverse effects, most of which are extensions of its pharmacological actions. These include hypertension, tachyarrhythmias, lactic acidosis, hyperglycemia, and reduced sensitivity to insulin. It does also increase myocardial oxygen consumption, which can result in ischemia, especially in susceptible patients such as those with ischemic heart disease.
That was a good answer, Maddy. So let's move on from the adrenaline to another very commonly used vasopressor in the intensive care. And you can also call it as a diligent, tireless, unsung hero of intensive care, that is noradrenaline. Can you please tell me a bit more about the mechanism of action of noradrenaline and its effects?
Sure. So noradrenaline is a naturally occurring catecholamine which is synthesized from dopamine in the adrenal medulla and released into the bloodstream as a hormone. It's also released by postganglionic sympathetic nerves as a neurotransmitter. So noradrenaline acts mainly via alpha-1 agonism through G-protein coupled receptors. This causes activation of phospholipase C, which causes increased IP3 and DAG. IP3 causes the release of intracellular calcium, which activates calmodulin-dependent enzymes that phosphorylate myosin light chain kinase, which leads to cross-bridge formation between the myosin and actin, resulting in vascular smooth muscle contraction. Thus, noradrenaline causes veno and vasoconstriction, resulting in an increased systemic vascular resistance and an increase in both the systolic and diastolic blood pressures. This can result in reflex bradycardia due to baroreceptor-related compensation. The increased diastolic blood pressure can result in increased coronary perfusion, but this can be offset by the increased myocardial oxygen consumption due to increased preload from venoconstriction, afterload, and coronary artery via vasoconstriction. Noradrenaline also decreases renal and splanchnic blood flow due to vasoconstriction. At higher doses, noradrenaline also has beta agonism effects that it begins to act more like adrenaline. As mentioned before, beta-1 receptors act via G-protein coupled receptors, causing activation of adenyl cyclase, which dephosphorylates ATP to form cyclic AMP. This results in increased intracellular calcium in the heart, which causes increased inotropy and chronotropy. But however, in practice, noradrenaline can have minimal effect and even decrease cardiac output due to the increased afterload from alpha-1 agonism.
So, what are the common uses of noradrenaline in ICU?
So noradrenaline is the best friend of ICU registrars everywhere, as it can be used in almost all cases of shock, including those of unclear etiology. It's most commonly used in septic shock. It helps counteract the vasodilation that occurs in cardiogenic shock and patients post-CABG, and it counteracts the hypotensive effects of sedation in patients and maintains cerebral perfusion pressure in patients with traumatic brain injuries.
Sometimes you see quite commonly in intensive care unit that patients are requiring escalating doses of noradrenaline, and then we commence vasopressin. How does the vasopressin work?
So vasopressin is also sometimes known as antidiuretic hormone. It's a naturally occurring peptide released from the posterior pituitary. Vasopressin receptors are also G protein coupled receptors, like a lot of the inotropes we discussed earlier. And they have two main classes, V1 and V2 receptors. So focusing first on V1 receptors, they're very similar to alpha-1 receptors, which noradrenaline acts on, as they are also G protein coupled receptors and cause smooth muscle contraction by increasing intracellular calcium through activation of the same mediators, IP3 and DAG. However, these receptors are more widely distributed and are independent of the adrenergic system. Furthermore, vasopressin's vasoconstrictor effect is preserved even in situations of severe acidosis, which is different from those of catecholamine receptors, which reduce their sensitivity as acidosis increases. These factors make vasopressin a useful adjunct to noradrenaline and can have a noradrenaline sparing effect. V1 receptors have also can cause platelet aggregation, increased glycogenolysis in hepatocytes, and ACTH release. The other type of receptors that vasopressin can act on are beta-2 receptors, which are present in the renal collecting tubules and are responsible for the antidiuretic effect of vasopressin. These are also G protein coupled receptors, and they activate cyclic AMP and protein kinase A, which causes the migration of aquaporin-containing vesicles to the apical membrane of the cell. This increases the water permeability of the cell, and water is reabsorbed from the tubules, causing antidiuresis. Interestingly, V1, which are the vasoconstrictor receptors, are present in the efferent but not the afferent arterioles of the kidney. This results in increased glomerular filtration and thus sometimes causes an increase rather than a decrease in urine output when vasopressin infusions are initially started. V2 receptor activation also increases the circulating factor of factor 8 and von Willebrand factor.
Okay. There are a couple of other inotropic agents that are used less commonly in ICU, mainly include levosimendan and Milrinone. Could you please tell me more about these agents?
Sure. So levosimendan is a calcium sensitizing agent. It does not actually increase the intracellular calcium concentrations in the heart, but rather increases the sensitivity of troponin C to calcium, which is already there. This causes positive inotropy. It also opens ATP-sensitive potassium channels, resulting in some vasodilation. Levosimendan is useful because it increases myocardial contractility, but does not increase myocardial oxygen demand, and thus can be used in situations such as severe cardiac failure. Milrinone is a selective phosphodiesterase type 3 inhibitor, which is the enzyme responsible for the breakdown of cyclic AMP. As we've discussed earlier, increasing cyclic AMP causes increased intracellular calcium, thus causing positive inotropy. However, an increase in cyclic AMP in the vascular system causes dilatation. So both levosimendan and Milrinone are inodilators. They don't increase myocardial oxygen demand and are useful in cardiac failure. Both of these agents are given as intravenous infusions, and a loading dose is usually given with both, although sometimes this is omitted with Milrinone due to the risk of hypotension. Interestingly enough, Milrinone has good oral bioavailability, unlike most other inotropes, but is only given as an infusion due to some studies showing an increased toxicity and mortality with oral Milrinone. Levosimendan is metabolized hepatically to active metabolites, which have a long half-life of up to 4 days. Hence, the effects of levosimendan can persist for days after the infusion is ceased. Milrinone undergoes a small amount of hepatic metabolism, but the majority is excreted unchanged in the urine and has a half-life of 1 to 2.5 hours.
Okay. Are there any particular set of patients in whom you will prefer levosimendan or or Milrinone over Noradrenaline.
These agents are commonly used in patients with cardiogenic shock, preferably in cases of biventricular failure because of their inodilator effect.
Okay, that's good. So, moving on to our last question for today, can you please tell me more about dobutamine?
Sure. Dobutamine is a synthetic catecholamine. Its pharmacology is actually quite interesting because it's a racemic mixture of two enantiomers. There's a positive stereoisomer and a negative one. So the positive one, if you just had that as an agent, would cause competitive alpha-1 antagonism and potent beta-1 agonism with less potent beta-2 agonism. The negative stereoisomer has a high affinity and is a potent partial agonist at alpha-1 receptors, but a low potency at beta-1 and beta-2 receptors. The result when both of these are combined is partial alpha agonism, full beta-1 agonism, and some beta-2 agonism. And as we've discussed earlier, partial alpha agonism can cause some vasoconstriction. Beta-1 agonism causes increased myocardial contractility, so that is positive inotropy, and beta-2 agonism causes some vasodilation. Clinically, this results in an increased heart rate, but minimal change in mean arterial pressure, as the vasodilation and vasoconstrictor effects often cancel each other out when using dobutamine. This only occurs up to a point, as the heart can only increase contractility so much, and after this point, there will be some hypotension. Dobutamine has a short half-life, no active metabolites, and is used for inotropic support in conditions of acute heart failure and cardiogenic shock. It is also sometimes used in myocardial stress tests. It can precipitate arrhythmias due to its increased heart rate action, and it does increase AV conduction and increase myocardial oxygen demand.
Okay, thank you. So that brings us to our last part of our podcast, that is a joke. So I'm pretty sure you've got some joke prepared for us.
I do. It continues on the theme of the heart. So what do you call a lie told by the atria?
A lie told by atria. I'm not sure.
A fib.
Thanks, Maddy. That's a really good joke.
I hope you enjoyed this episode. We will be back soon with another episode on cardiovascular pharmacology, and in that episode, we will discuss in detail about antiarrhythmic agents. Till then, goodbye and have a nice time.